Good morning. My name is Angele Bradardin. I am the manager of patient services at the Georgia Transplant Foundation, and welcome to the Liver Room. We have a few things to go over today. First, the session is going to be recorded, and we will share the link with you by email once the event is over. The links will also be in the website. Please keep yourself muted as any background noise in your home may take it away so that we cannot hear the physician. You will You will not appear in the recording, but if you unmute yourself for the questions, your voice will be on the recording. You can also use the chat box for questions you would like to ask, and I will be happy to ask them at the end. Without further ado, I want to introduce to you Dr. Wedd. Dr. Wedd is a transplant hepatologist with a clinical and research focus in the diagnosis and management of liver malignancies. He is the director of the Liver Tumor Clinic at Emory, and also an associate editor of Liver Transplantation. He is a husband, father of 2 girls aged 2 and 5, and as a hobbyist woodworker in his spare time. Welcome.
Thank you so much, Angel. It's really great to be with you guys today. I'm going to share my screen in just a second, but before I do that, if you're willing, could you raise your hand if you're post-liver transplant? Okay, or raise your hand if you're pre-liver transplant, haven't gotten a liver transplant yet. So from the people, everyone seems to be post-liver transplant, which means you know intimately a lot of the stuff I'm about to go through. Let me share my screen here. Good, is everybody seeing that?
No.
Okay. So the talk that I'm going to give you today is called Organ Transplantation, Current State Updates, Challenges, and How Your Providers Think About It. So it's a long title, but it's designed to give you a very broad view of transplant in general and some of the concepts we think about. However, some of those concepts are challenging. If they are new to you, just try to get the very, the focus on the very basics of it, just to get an idea of what it means. And this is the stuff that, I love taking care of patients. I love all the great things that come from being a physician, but these concepts I think are really, really fun. So I enjoy presenting them to you today. So this is the outline. What do we transplant? What organs do we transplant? Then we're going to talk about scarcity. Scarcity is what drives a lot of our policy, a lot of our decision makings, because we just don't have enough organs to go around, and what ethical principles we use to navigate that scarcity, which will put us into who do we transplant, how do we rank a waiting list, and we'll use liver as the example, of course, and then switch directions to what does post-transplant care look like. I'll mention a couple slides about COVID and about what the future looks like. Now, that's going to be the didactic portion of this, me talking at you. That'll be about 25 to 30 minutes to go through that stuff. And then what I have is an opportunity for discussion based on a few cases of someone who may or may not be a liver transplant candidate. And I've given versions of this talk before in person, and those cases are often a lot of fun and very, very interactive. This is the first time I've done it by virtual on Zoom. So we might, what I'll probably have everyone do is unmute when you want to say something and when you have a question, but then go back to mute. But I want it to be somewhat a free-for-all, and I want everyone to participate. The more you participate, the more fun it is. Okay, so we have 30 minutes or so to do that, plus any other questions that we can do at the same time as we're discussing the cases. So whether we go a full hour is kind of up to how much you guys feel like participating today. So let's start with what do we transplant, meaning what organs, what body parts do we transplant? This is just a single slide to give you an idea of all of the organs that we transplant and when they were first, quote, successful. Successful probably means something like the person was able to live for another few months. But back at the beginning of transplant, the ability to have adequate and safe immunosuppression was a major barrier. And that's why I highlighted cyclosporin as a calcineurin inhibitor that was released in 1983 And calcineurin and its, cyclosporin and its cousin Prograf are just changed completely the way patients and their organs did after transplant. So you see the first kidney was back in the 50s, then you had a kidney panc in the 60s, as well as liver, pancreas, and heart. That liver was done at University of Colorado by a guy named Thomas Starzl, who's pretty much the godfather of surgical liver transplantation. And then you have a host of other, doubles or combination organs getting transplanted the decades after that. What this does not include is things like retina or face transplants. Those things, especially the face transplant, was big in the news over maybe a decade ago, and those things are still happening. So with that, I want to talk about scarcity. And as I mentioned in the intro, scarcity just means that we don't have enough livers, we don't have enough organs for everyone who needs one. And again, it drives our decision-making, it drives our practice, it drives the laws that we have to obey for getting people organs and policies. It drives pretty much everything. Things would be dramatically different if someone needed a liver, we could just get them one in next Tuesday, but it doesn't work that way, as you guys know. Until we can do this, until we can grow, livers and kidneys in a vat or a microwave somewhere, we're going to have scarcity. There are more than 120,000 people awaiting liver or transplant in general, and someone is added to the list every 10 minutes, and 20 people die awaiting liver transplant every day. This graph shows you at the top the number of people waiting at the end of the year for their, in this case, liver transplant. And at the bottom is basically markers of people getting that liver transplant. This gap is the problem. Far too many people who need it compared to people who receive it on a yearly basis. And so when you have scarcity, when you don't have enough of a resource, you have to find ways to use that resource for the best for the individual and for society. And so we have to think about it. We're doctors. We think about our patients. We want to do the best for our patients, but we have to think about the broader societal good. When these organs come out of a donor's body and before they go into a recipient's body, that organ belongs to everybody. Okay, and so we have to be responsible about how we use them. And so some of those ethical principles on the individual level, we think about beneficence, which is do the best for your patient, for the patient. Futility, don't do something that's not going to help them. Non-malfeasance is don't do harm. And then the societal ones, distributive justice, rationing, and utility, are all geared to making sure we're using them the best possible and not wasting organs, for lack of a better term. And so in that frame, we are all stewards of this resource. That includes the general public, patients, the transplant community as a whole, transplant programs, and all the providers and staff. So every individual in this country is a steward of this scarce good. And so we're all responsible for making sure they are used equitably. So with that in mind, who do we transplant? When you have scarcity, you have to carefully select patients who are going to do well and who need the transplant. And then you have to figure out a way to prioritize because you have too many people waiting. So this is just, and you guys know this is just the put here to display how difficult it is to get through from diagnosis to transplant. There are so many steps, and at any time, at any step, a patient can fall off and not make it to the next step, whether that be an issue with access to care, whether it be the severity of their underlying disease. All sorts of things can trip up the patient on their journey to transplant. So the first step after developing the disease is someone has to recognize that the patient has it. If they are in the realm where they need a transplant, then it must be referred to a transplant center. Then that patient must be deemed appropriate for a transplant evaluation. Then the transplant evaluation has to be successful so that the patient is deemed appropriate for waitlisting. Then they have to develop priority, however that happens, and it's different for different organs. Then they get to the point of transplant, and then they move on to post-transplant care, which is lifelong. Post-transplant care never stops. And so some general concepts of how we think about patients for candidacy, well, I mentioned they have to have a need for it. So we usually define that as someone who is at high risk of dying if they don't get the transplant, That's the first guiding principle. The next one can be quality of life. So we do often justify doing transplantations for someone whose quality of life is poor because of their underlying organ dysfunction, even if that doesn't directly translate into as high a risk of dying from that problem. And then the flip side of that coin is making sure that there's a good chance of success with good outcomes after transplant. And that's where we really think about a lot of the underlying medical, surgical, and psychosocial aspects of the patient's life to make sure that they are likely to do well from the surgery and after the surgery for as long as possible. And so the same type of balancing is happening again that I talked about with the ethical principles, but this time it's divided into urgency. How urgent does a patient need a transplant? What's their risk of dying? What's their quality of life? But balanced by outcome. So on the urgency side, again, you have mortality risk, quality of life. On the outcome side is all the downsides to transplant. You know, transplant is not a perfect panacea. You are trading the terribleness of your liver disease for the downsides to liver transplant, and they are an upfront risk of a major surgery, the care burden associated with post-transplant care, and the short and long-term risk of the immunosuppression medications. And so we are balancing those things when we're thinking about transplant candidacy, and the individual aspects of the patient's medical history, surgical situation, psychosocial situation impact those portions of the outcome. Some of those general concepts, medical-wise, we think about age. I like to say that there is, age by itself is never a contraindication to transplant, meaning there is no age at which I would say it's impossible. But the truth is, if you're thinking about societal good too, if you have a 90-year-old, even if they're in great shape, well, their chance of benefiting long-term from a transplant is quite low. In fact, they're likely to do very poorly with the transplant itself. So that patient really isn't going to be a transplant candidate. We frequently, though, find patients in their 70s who we think are reasonable candidates for transplant. Other medical issues that can be a problem, diabetes, especially long-term diabetes, increases a lot of the risks around surgery and the risk from the immunosuppression regimen. Heart disease, same problem. Other organ dysfunctions can complicate this. If you have liver failure and kidney failure, if you have, sometimes we might have to do a combined liver and kidney. If you have liver failure and heart failure, well, that's a major problem. And often those people are not candidates for anything. Cancers around the time of transplant are a problem other than cancers that are inside the liver, because when you do the liver transplant and you put someone on immunosuppression, well, those cancers are often going to get worse because the immune system has a role in controlling cancers, and if you suppress it, it makes it worse. So someone with another cancer at the same time that they're trying to get a liver transplant, for example, is generally not a candidate, with some exceptions. And then the social issues I mentioned, active social substance abuse is a serious problem because people who are engaging in alcohol use or other drug use are just less likely to do their follow-up, to take their medications, in addition to the risk that it might do direct harm to the organ that they've received. I mentioned support. So, you guys know how hard it is to get through the transplant process. And then for the first, 2 months, you have so much visits, so much contact with the clinic and with the transplant program, that you really need healthy support system in order to get that done. Usually more than just one person. You have to have access to transportation, unfortunately, because some people don't have access to that. And if those things aren't in place, well, you're not going to do as well, and that's a consideration. Insurance, unfortunately, must either be in place or there must be a way to get insurance. We would love to transplant everybody, even if they didn't have insurance, but there has to be some way for them to be able to get their medications after transplant, or else you're not doing them any favors. You're actually putting them through something futile. And if you remember those ethical principles I mentioned at the beginning, futility is not good. And then sometimes patients don't understand how much we need to make sure that they can interact and cooperate with us. I mean, patients are going through a really tough time and they don't want to lose autonomy, of course. And when we're telling them to do something and we're saying you should do this for this reason, and they don't want to, there's a back and forth there. and we try to be understanding, but if it happens again and again and again, well, then we get concerned that that's what's going to happen after transplant too, and that person is going to do worse because of it. So we have to think about those issues with patients as well. So next, how do we rank the waiting list? And I put the same comment here that I put before the last section, and that's scarcity is driving that we need to do this at all. And so that's why we have to think about careful selection, and that's why we have to prioritize so that, you know, it's like if you have a room full of 30 people and nobody can eat anything but pie, but you only get 10 pies a day, well, you're gonna have to figure out how to share that with that room. And this is kind of similar. It's everyone, you know, a lot of people need an organ. Who gets it first when you don't have enough?
And the last thing is, if you've been on dialysis for a long time, your waiting time goes back to when you started dialysis. So if you've been on dialysis for a while and not been referred to a transplant center, definitely should look.
So I wonder if someone has their,
Living donors.
are you guys hearing that? Okay.
I had a question.
Sure.
Does prolonged Prograf, I've had a transplant since '08, and one of my VA doctors told me that Prograf, he liked to check on Prograf because it has an effect on the kidneys. And my VA doctor wants me to come in and talk about the kidneys, but I don't think I had a chance to mention that Prograf might cause problems with the kidneys.
So we're going to go through the downsides to the medications in a little bit. But to answer your question, yes, Prograf and the calcineurin inhibitors can cause problems with your kidneys.
Thank you. Yeah, I have an appointment. I'll have an appointment with my VA doctor, and I guess what I take 2 twice a day. I used to take 3, and he reduced it to 2, and
Sure.
I'm assuming they're probably going to reduce it to 1.
Yeah. Why don't you? We'll keep going with the talk because I'll cover some of these things, and then if you have remaining questions after that, we can discuss it in the discussion period. Okay.
Oh, thanks for your time. I had my transplant at Piedmont, and all my doctors are gone from there.
Great. Yeah, I see. So this I'd like to present as kind of a paradigm for thinking about prioritization. And this is, you know, one of the concepts that's a little bit higher level. So just, you know, if you're not familiar with this, just think about it at a very broad level. We think about prioritizing based on those 2 things that I've been talking about: urgency, how quickly do they need it? Outcome, how well are they going to do? And we use those to determine what metric we're going to use to rank the list. It might be a single metric, it might be multiple things together. The gold standard, if you can do it, and it's not the same or it's different for every organ, is to combine those into some sort of measure or way of measuring utility. So how well is this organ going to be used? And that's a combination of how much the patient needs it and how well they're gonna do. There might be someone who really needs it, and it's so bad that, you know, taking the chance that they won't do quite as well at 3 years or 5 years or 1 year even might make it worth it. On the flip side, there might be someone whose urgency isn't, you know, tomorrow, but they're going to do so well, they do need it, and they're going to do so well that it would make sense to go ahead and move forward. And so I'm going to talk about how all these 3 come together in organ transplantation. 2 more quick concepts. Definitions of allocation and distribution. Allocation and distribution are combined for prioritization. Allocation is what do we use to rank the list. In the case of the liver, I'll go through this, it's the MELD score. Distribution is kind of how do you navigate that list? Once you have an organ is in there to be offered, how do you navigate down the list to figure out who actually gets it? And it usually includes some other variables. The most common extra variable is geography. So where you live relative to that organ matters. Why does it matter? Because travel distance equals time, and the longer an organ is outside the body, the more likely it is to develop damage and not work as well. In fact, you know, kidneys are probably the most forgiving, and they can last 24 to 36 hours, especially now there's kind of infusion options for the kidney while it's outside the body. But a liver, 8 to 12 hours, heart and lung, only 4 to 6 hours. It's hard to take a lung from the East Coast and ship it to the West Coast because it's not gonna work as well. And so these things have to be thought of when you're going down the list and offering these organs. These are some of the factors that go into the different organs. Kidney has got a lot of waiting time involved. They also have to think about the immune system between donor and recipient. If they've given a kidney before, that can be in their favor. How far they are from the donor is important, and then survival benefit, which is that outcome factor being included. Lung has survival benefit as well. Actually, survival benefit is really a utility measure. It is outcome and urgency together. Medical urgency, waiting time again for lung, distance from the hospital. Heart and liver don't have any waiting time, and they're really all urgency with distance from the donor hospital. So we're going to go through a lot of liver here just to understand how this is done. You guys should be somewhat familiar with this already, although there are some nuances that maybe you didn't understand. And it's important as recipients of liver transplants and part of the general population to understand this. So back in the 90s, livers were allocated based on waiting time and where the patient was, where the recipient was, whether they were at home or in a hospital or in an ICU, and whether they were at home versus hospital ICU is a measure of their urgency. Unfortunately, it was associated with gaming the system, so people would just take someone from home and put them in an ICU in order to get them access to a liver quicker, even if they didn't need that liver. And that's, doctors are people too. They're trying to help their patient. That happened all the time. And also, this study shows that waiting time doesn't matter. If you're waiting longer, it doesn't necessarily translate into a higher risk of dying. So because of this, the Department of Health and Human Services issued the final rule, roughly 2000, where we were mandated to focus on the severity of the disease and waitlist mortality risk instead of on waiting time, prioritized by urgency of transplantation, develop a continuous and objective scoring system, not like the home versus hospital versus ICU, and improve the overall equity of the system. So this is where you guys were probably, very, very familiar with the MELD while you're waiting for transplant. And I like to call myself a MELDologist because MELD is like the Bible of liver disease and especially liver transplant. What is the MELD? The MELD is three blood tests that go into an equation and give you a number between 6 and 40. And that number predicts your risk of dying in 3 months from your liver disease. So the higher the MELD score, the higher the risk of dying in 3 months. So the transplant community said, all right, this is great. This is the objective scoring system that the final rule wanted us to do. Let's start using this for transplant. And it was instituted in 2002, which dramatically changed liver transplant in the United States. It was good because it was reproducible. It's the same equation every time. You just need the lab work. It's reliable for the same reasons. It's discriminatory, meaning there's a clear difference between someone with a MELD score of 40 and someone with a MELD score of 6, and there's delineations in between. So you don't have people lumped into 2 or 3 groups. You have 34 groups that they can be lumped into. And people don't kind of get stacked up in the same place. And it's accessible, which means you can get your labs drawn in any clinic, in any lab in the United States to get your MELD score calculated. The other thing it allowed us to do is to figure out when it really is reasonable to start moving towards liver transplant. And that's because the MELD score predicts risk of dying. We also know the risks associated with a transplant. And it turns out that if your MELD score is less than 15, the risk of going through a transplant is higher than keeping your liver. And then that flips when the MELD score is over 15. And so that's useful clinically for us and for explaining it to patients why we're moving forward with transplant now versus waiting. So again, objective and excessive variables, the MELD immediately improved ability to stratify based on transplant urgency and improved transplant access for sick patients. It was overall a great success. However, the MELD score is not perfect. And as you guys might remember, there are other labs and other clinical factors that go into that impact a patient's chance of dying while waiting for transplant that aren't included in the MELD score. For example, the sodium in the blood was added to the MELD score a couple years ago because it was a predictor of this. So now we use the MELD sodium as the way to rank the transplant list. Clinical factors such as ascites, problems with confusion, those are not included in the MELD score. So someone might have a relatively low MELD, but significant problems with fluid or confusion, and maybe they're being under prioritized by the MELD score. The biggest example of this is something called hepatocellular carcinoma, or HCC, and you guys might be familiar with that. It's a liver cancer. Everybody with cirrhosis is at risk for developing it, about 2 to 3% risk per year. And if you develop it, then you have an urgency to get transplant as a cure for the cancer, but often those people's liver function's okay. So their MELD score might actually be 6, but they have a cancer. And if all we did was rely on their MELD score, it wouldn't be fair to them. And so in addition to continuing to revise the MELD score and analyze the results to see what we need to change and search for better predictive scoring systems that can either go with the MELD or replace the MELD, they had to develop, and we have in place, something called exceptions for the setting in which patients' MELD score is not really telling the whole picture. And that hepatocellular carcinoma is a perfect example of that because it's the most common and probably the easiest to understand. So the way it works with exceptions for HCC and a lot of these things is, at least traditionally, that patient would get some MELD score that was given to everybody with that problem as long as they were within certain criteria. It was most recently 28 MELD points. And then it would go up every 2 to 3 months, every 3 months by 2 to 3 points until that patient got transplanted, or until at some point they started capping at about 34. And so that would get opportunities for those patients to get transplanted. In a couple slides, I'm going to tell you how that has changed recently and why. But that has been, that was traditionally how it was done. And people can get exceptions for having ascites. It's harder to get those because it's not automatic, whereas the hepatocellular carcinoma is. But you can get that. You can have, there's lots of reasons why you might be able to get an exception. These days, it's up to a national review board if they're not automatic exceptions like HCC. A word on distribution. This is traditionally how liver has been distributed. So you have your rank of MELD scores, but the geography of it, as I said, matters. Traditionally, there were 11 regions in the United States, and those are subdivided into things called donor service areas, or DSAs. And so those make the geographic building blocks of distribution. And so up until recently, it's another change that I'm going to mention in a couple slides. This is the way that livers were distributed. First, you'd have patients who status 1A, or just they meet criteria for basically acute liver failure. And they're considered sicker and higher need than any MELD in a chronic liver disease. So those are offered locally to the DSA first. And if no one's there, then they're put out regionally to the whole region for status 1A. If nobody gets those, it goes back to the local for MELD score 35 to 40, then regional. Nobody gets it there, it goes to local for any MELD over 15. Nobody gets it there, it goes to regional, then goes to a national sharing model. So this is a way that they incorporated both the MELD score for allocation and the geographical units for distribution, so that you're not sharing too broadly, but yet sharing enough. Unfortunately, in this system, there was still a lot of variability. And variability means lack of equity. So someone in this donor service area here would be likely to get a MELD score at about 18, whereas someone in this donor service area would be likely to get a transplant at MELD score 31. This person would have to wait a lot longer only because of where they live. And so that is actually contrary to the final rule and needed to be addressed. And again, in a couple slides, I'll show you how that's been addressed recently. Or I'll do it in this slide. So the changes recently, one to exception points that I mentioned, or one way to get things like hepatocellular carcinoma priority for transplant. In 2019, instead of that 28 points and then 3 months later, 30 points, and then 3 months later, 32 points, all the way up to 34, that was changed to something called the median MELD at transplant -3. And what happens is, for the area that the patient's in, basically the average MELD score at transplant for everybody for the last 6 months is calculated. And if that number is, say, 28, well, then the patient with this exception would get 25 points. and they would sit there. In 6 months, it'd be recalculated, and they'd still sit at 3 points under that average. The reason this was changed was because the patients with these exceptions walking up and up and up and up, they were actually getting over prioritized compared to patients who had, chronic liver disease and their MELD score reflected by their liver disease. And so this actually reduced the prioritization for patients with exceptions, like for hepatocellular carcinoma. It's changed dramatically what I do, because I see a lot of patients with hepatocellular carcinoma because I direct a liver tumor clinic, and it's harder to get them transplants now. And it may mean that we have to use more living donation. And that's all things that I think everyone across the country is thinking about right now. The other major change was a completely different distribution model. So you remember that I showed you the regions and the donor service areas, as that was the baseline for geography and distribution. The problem with that, one place can have a MELD score of 18 to get a transplant, and another a MELD of 31, was taken to heart. And the transplant community changed it into a concentric circle model. So there's a circle drawn around where the donor is at 150-mile radius, another one at 250 miles, and another at 500 miles, and they're offered based on those concentric circles. As I'll mention briefly, there are some advantages to that for some areas and disadvantages to others. So this is just a graphic depiction. If a liver comes up here, first it's going to be offered for everybody within this 150 square nautical mile distance, and it goes status 1A first. If there's nobody in 150 status 1A, it goes up to 250 and then 500 before going down for anybody with a MELD score greater than 37. 150, 250, 500, then down to 33 or 36, 150, 200, 500, and so on until you get down below where they shouldn't be transplanted. And this has changed, especially in our area. It's shunting livers away from Georgia, for example. And that's just, it's just a quirk of the program, partly designed because I think our patients were benefited in getting transplants earlier than other places. But still a problem and very controversial for a lot of areas. And then I put in the example of Miami, for example. Miami is basically on the tip of a peninsula, so the majority of the area around them is water, and they're not getting any livers from water, right? So they are probably severely disadvantaged by this model because of that. Just a couple brief comparisons so you understand what some of the other organs do. Kidney, very heavily influenced by waiting time for getting their organs. And that's because they have dialysis. They have something that can temporize the need for transplant and something they can do while they're waiting. So waiting time is important. And then they're matched heavily by immune compatibility. It just happens to be more important with the kidney than liver, for example. Lung has an allocation system that uses utility, and it's a complicated metric. It's got lots of variables. I don't pretend to understand it because I don't do lung, but it's got urgency and outcome combined in a single variable that they're ranked. And so the idea is to get the right organ to the right patient that's going to maximize its use. And they also have been using concentric circles for a while, just like liver recently adopted. Good. So that's everything you need to know about how people get liver transplants. Now let's talk about post-transplant care. Yes.
I have a couple comments on the scarcity and distribution.
Sure.
Right now, about 20 people die every day waiting for transplant. And the donation rate, I analyzed this state by state, and the organ donation rates vary widely around the country.
Mm-hmm.
California and New York are at the low end. And if you match that against the graph you put up about the MELD score and their donation rate, you'd see a high correlation. In fact, I analyzed this very carefully. The DMV is where the bulk of the signups go. And I analyzed how the question is asked at the DMV. And there are ways you can ask the question that get higher response rates. For example, Missouri offers you 3 options, and it asks the question in a favorable way. In order to save lives, would you like to be an organ donor? And you have 2 ways of saying yes. One, yes, and put it on my driver's license, put a little heart on it. Or say yes and don't put a heart on my driver's license, or no. if every state did it the way Missouri did it, we actually we'd be near 0 deaths per day because of the wide variation in the way the questions are asked. For example, New York is probably the worst. You have to actually sign and date the section that you're saying yes to. And there's a lot of words about legalistic things about it. And it's very negative, kind of almost encouraging you not to do it. In fact, one of the options is skip this question rather than sign and date and all that other sort of stuff. Yeah. It's a very poor way of doing it. I've analyzed this, and I'm going to put in a link here to increaseorgandonation.net, where I've studied this and made some recommendations. Donate Life America is starting to analyze this a little bit, but it has the potential of reducing the 20 down to near 0, actually, if you use Missouri's rates. This is, I'm trying to get the word out, and maybe you could help spread that. I was transplanted at Piedmont, and a lot of the doctors at Piedmont know about this, this project that I've been working on. And I'm trying to spread it out so we can get the states to change. And it's a little complicated because every DMV has their own, goals of how they do things, and they don't want to spend extra space on their forms and so forth. But with the computers now, that's shouldn't be an issue. But I encourage all of you to go take a look at that and see how you could contribute to influencing people around the country to change the way they do it. Because it is a very simple solution, but it's hard fighting bureaucracies.
Yeah, that's really great information. Thank you. A little bit later in my talk, just in a few slides, actually, I talk about the future and how do we ameliorate some of this scarcity. And that's one of the things, if you improve donation or you improve procurement of people who are potential donors, then you help to narrow that gap. And so I put it in briefly, but the fact that you made a comment sets up that that concept very, very well. You can either have fewer people, you can either have more organs or fewer people that need transplant, basically, is a way to shrink this gap. And so I'll show you that in a couple minutes. So let's briefly go through what transplant care look like. You guys are all very well versed in this. There are a host of potential immunosuppression medications that are frequently used in the liver transplant setting. Steroids, usually in the first month or in the setting of a rejection. Calcineurin inhibitors, those are the Prograf and the cyclosporin that revolutionized transplant care a few decades ago. Mycophenolate is usually on the list, especially early. Some people get a medication called basiliximab, especially patients who are getting kidneys as well. And then mTOR inhibitors are Rapamune and everolimus. And so I'll just, usually after transplant, patients are in a combination of prednisone for steroid, Prograf, and CellCept, okay? Then after about 3 months, the steroid should be off. After about a year, I tend to try to take the CellCept off, depending on patient situation. And then in the future, I try to limit the Prograf as much as possible. You're trying to find the lowest amount of immunosuppression that the patient can tolerate without getting a rejection. And we don't know where that is when we start the process of reducing immunosuppression. So sometimes it's trial and error, for lack of a better word. And the reason we do that, the reason we reduce, is because all of these medications have side effects that can disrupt quality of life or disrupt longevity of life over the long haul. They all increase risk for infection. Several of them can cause problem with blood sugar, make diabetes worse. They can make hypertension worse, blood pressure worse. They can reduce or increase the amount of fat in your blood. They can reduce your white blood cell count and your red blood cell count. They can impact wound healing. And then, as we mentioned earlier, the calcineurin inhibitors like tacrolimus and cyclosporin will cause chronic liver disease over a long time. And so reducing these as much as possible are important. Keep in mind also that these side effects impact our decision-making for who's able to do well after transplant, because if they have terribly controlled diabetes, well, guess what? What's going to happen when you put them on high-dose steroids right after the transplant and then they're on these medications long-term? It can be a deal breaker for transplant candidacy. Or if they have, chronic kidney disease already, it's going to get worse after transplant. Those are the people we have to see if they're candidates for a liver plus a kidney. And so this is just the point I made. The goal over time is to reduce the amount of immunosuppression. Liver, pretty lucky. It's actually a pretty immune tolerant organ, lower risk of rejection compared to things like kidney and heart and lung, not zero risk. So you can never totally stop the medications, but we're able to get that, that immune suppression lowered over time. What about the care burden that I mentioned? That
Dr. Wedd, I have a question. There was a study done in London maybe a dozen years ago or 5 to 10 years ago on hepatitis C patients with liver transplant. I think there were about 34 of them, and they took them all off of immunosuppressants. And it turned out that 17 of them, or half of them, had to go back onto immunosuppressants. They started rejecting. The other half did not need it, actually.
Yeah.
And has there been a follow-up to that study, or?
Yeah, I think the majority of data would call that very optimistic. We certainly try to reduce as much as possible, and there have been a lot of studies trying to figure out, hey, can we select patients who will be able to ultimately come off of immunosuppression? And all of them have been either unsuccessful or just not able to get a high enough percentage to make it worthwhile, meaning it would put too many people at danger to try to do that. So the rubric is people are going to need to be on immunosuppression their whole lives. Sometimes we have a happy accident where someone is not doing well with their medication adherence for whatever reason, and it doesn't cause a problem. The vast majority of people that I see who stop their medications for whatever reason get a rejection. Okay. So care burden, the other side of why you need a lot of support. The hospital stay itself is going to be about 8 to 10 days after transplant. The quickest I see people get out of the hospital is about 5 days. And I've seen people have it stay in the hospital for months after a transplant if there are complications. After you get out of the hospital, about 3 times per week for the first 6 to 8 weeks, either to see the surgeon or get lab work, and then slowly space it out after that. So in my practice, after about a year, I'm seeing patients every 6 months, and then even move to a year as they're getting closer to 5 years because they've got so much stability. So a lot of care burden up front, but it gets better over time, similar to that immunosuppression. So if anyone on the call is, or on the in this lecture is recently transplanted, expect things to get better, both from an immunosuppression and medication side effect perspective and care burden perspective. And I just put this in to show what happens if you don't get through the care that you need, and what happens if you don't keep on the medication. In the majority of cases, slip-ups result in worsening liver function. And you can get what's called chronic rejection. So if you have acute rejection, it gets treated. And I'll give one slide on that in a second. Chronic rejection, if it is recurrent or severe rejection, eventually can't be treated anymore. And that person will need a new liver transplant if they're a candidate. Keep in mind, if they weren't taking their medications with the first one, and that's the reason why they have chronic rejection, they're not going to be a candidate for a new transplant. So their non-adherence has basically ended their life. So what is rejection? It is the immune system reacting to the foreign organ. The risk of rejection varies by organ. It's, as I mentioned, the least in livers. And the treatment is to increase immunosuppression. If it's just mild rejection, and this is a mild, moderate, severe is a staging system based on the way the liver looks under the microscope, it might just mean an increase in the oral medications a little bit. But if it's moderate to severe, that usually results in someone in the hospital getting intravenous steroids, and sometimes even includes stronger medications, something called thymoglobulin. And all of those have their own set of side effects. So it's better not to have a rejection. Okay. And again, as I mentioned, if it's untreated or it's recurrent and severe, that will ultimately result in loss of the organ. So what's the future look like? We've been talking about scarcity a lot. How do we fix that? So there are 2 ways. Either you reduce the burden of liver disease, you reduce the number of people that need transplants, or you improve organ availability. So one example of reduced burden is hepatitis C. So classically, hepatitis C has been top 2 reason for transplant for decades. It results in cirrhosis and liver failure. It's a major driver of liver cancer too that results in liver transplantation. But what's changed in the last 5 to 10 years is a dramatically improved choice of regimens that are tolerable and 90 or more percent, approaching 100% effective. So whether you're treating the person with cirrhosis already or treating the person who just got infected, you're reducing the burden of need from hepatitis C in the future to improve that ratio of number of patients who need transplants and the number of transplants available. Unfortunately, there's another epidemic going on in the Western world, and especially in the US, and that's non-alcoholic fatty liver disease or non-alcoholic steatohepatitis. And this figure is just to give you an idea of how big a problem this is. It takes the place of all of the benefits we're getting with treating Hep C by putting more patients in from NAFLD to NASH. So if the US population is about 320 million, plus or minus 10 million, 30 to 40% of them have non-alcoholic fatty liver disease. That could be as high as 130 million. 5 to 20% of those have inflammation related to the fat. So that could be as high as 25 million. And about 2 to 5% of those develop cirrhosis. So that could be as high as 1.3 million patients in America right now with cirrhosis from NAFLD to NASH, and it's growing. So that is a problem in the future that's going to potentially worsen the scarcity issue. So what's the other thing we do? How do we improve organ availability? As Steve mentioned before, you can work on improving donation rates. And so it might matter how it is, how people are asked to donate at the DMV or whatever. And that's an important part of the equation to try to improve it. I mentioned that some donor service areas have, it's harder to get a transplant in those areas or another, and some of them are just underperforming. Those are called organ procurement organizations. And New York, California, for example, tend to have lower procurement. And if you can focus on those areas, figure out what's going on, and maybe make an improvement, it improves some of this disparity. Broadening what livers we accept. So some livers are turned down for various reasons. One opportunity is to accept what's called donation after cardiac death. So in the setting of deceased donation, patients who are brain dead, they go to procurement. They have their organs procured while their heart is still beating. And that allows the organ to continue to be perfused until it's taken out of the body. In the setting of donation after cardiac death, there are rules. So it's someone who, they're not brain dead, they're donating for various reasons, but they're not brain dead. And you have to wait for their heart to stop and give it a certain amount of time by law before you can declare them dead. During that time, they're not getting perfused with blood, and that can cause issues with the liver. So if we improve that, or just have a lower threshold to accept those organs, it can close that gap on the transplant list. Extended criteria organs include older donors who have drug abuse history, et cetera, that might have been passed up in the past that we can work on accepting more frequently. And then one big change recently is accepting donors from hepatitis C positive donors and giving them to recipients who don't have hepatitis C. And it invariably will give the recipient hepatitis C. But because of all the advances in therapy for hepatitis C, they're so likely to be cured that not only do we do this frequently, it's covered by insurance, et cetera, et cetera. So that's one good way to improve the donor pool. We can improve livers by having better preservation strategies outside the body. This is particularly true in kidney, for example, where they have infusion pumps. But this has been important in the research realm for livers as well. Xenotransplant is taking organs from a different species and giving it to humans. And then stem cells might be an important avenue in the future for getting patients or for getting more livers. So how do stem cells work? You can add cells to a functioning organ, or to ameliorate a poorly functioning organ. So you can get a donation of pancreatic stem cells because your pancreas doesn't work. They put it in the liver and they act like pancreas cells there, and it helps with your insulin and your glucose. And so that is one stem cell application. Another one with lots of focus is, can you take stem cells, put them in some sort of matrix, and grow the complete organ? Can you grow a liver using stem cells? And there's a lot of work being done. Of course, it's not prime time yet, but that would be the growing it in a vat thing that I talked about towards the beginning of the talk. And that would go a long way to improving scarcity. Just one brief word on xenotransplant. So again, taking something from a pig, for example, and putting it in a human. There's research on this, research going on at Emory. It's limited by these things called porcine endogenous retroviruses. Fortunately, there's been some advancement in gene editing technique, but again, this is not prime time. It's just something maybe in the future that might be possible. Couple brief words on COVID-19. So I like to mention this. You guys, if you're post-transplant, you're immunosuppressed, you know that your risks are higher from COVID. If you get COVID, you're more likely to have a severe course. But I tell my patients who haven't had transplant yet that they're also immunosuppressed because of their chronic liver disease. And so they're also at increased risk. So both the post and the pre are increased risk for severe COVID infections. There's not a whole lot of specific data on that. Recommendations are limited overall. However, there was liver injury being described pretty consistently from COVID infections. So if you had an underlying liver disease and had liver injury from COVID, it might be more likely to be severe just from the liver perspective too. These are just some of the CDC guidelines. They recommend, you guys to take steps that anyone could take to prevent getting COVID: masks, social distancing, hand washing, all of that stuff. Take the same preventative actions, same things. In addition, it's good to make sure you have enough of your medication at home so you don't have to make unanticipated visits to a clinic where you might get exposed. Make sure you're vaccinated for everything else, so protect yourself where you can. So it's Hep B, Hep A, flu, and pneumonia. And if you must stay home for a couple of weeks, make sure you're able to continue your care. So if you get infected and you have to quarantine at home, make sure you have a portal or some sort of telemedicine or contact with your transplant center to keep the care going. And then it's important to stay connected socially as much as possible while still being safe. And people have found, Zoom or online or what's FaceTime or whatever to be a substitute for that, to make sure you're getting some of that social interaction. If you're a smoker or a vapor of tobacco or marijuana, you're going to increase your risk of having a bad lung reaction to COVID. So you should try to quit. And then if you become sick, make sure you stay in touch by phone with people so that if things get worse, someone knows about it. Great. Good. So that is the didactic portion. I'm not sure where we are on time. We started later. Why don't we give people, if anyone has a question right now.
I have one comment.
Yes.
Governor Kemp has issued executive orders every couple of weeks for the last 6 months. And there is a shelter-in-place order for anybody that's had an organ transplant because of the immunosuppressants. So, except for essential work, I would recommend looking at the wording of that we are under a shelter-in-place order.
Yeah. And I think people just need to be smart, realize their risks. Orders, I think, from a public health perspective, are helpful. Not every state's going to do that, and it's going to vary case by case. But you got to be smart when you're immunosuppressed. Hopefully, this will be less of a problem in 6 months, but I don't know. Okay.
Can I say something real quick?
Yes.
We're talking about availability of livers. Once I say this, you're going to be familiar with it. But back in 2017, I signed up for a special program to accept an HIV liver.
Yeah. Yep.
And I was the first one to get an HIV liver.
I remember. Yes, I remember our first one. That was you, huh?
Yep.
So that's called the it's called the Angel Act, I think.
I'm not sure. Yes, I
can't remember. And it comes up, and it's a wonderful opportunity. I mean, 10 to 20 years ago, people with HIV weren't getting transplants. Now there are very clear criteria to allow them to be transplanted and include the opportunity for more of a donor pool if the donor happens to have HIV too.
Well, I was told that President Obama signed off on that before he left office.
Maybe he did.
I'm indeed thankful for that. But just to touch on something else, we were talking about the MELD score. At the time I got the transplant, I was feeling pretty lousy, but my MELD score said something like 12 to 15.
Yeah.
And I couldn't get it to go up. And this is the kick about the MELD score. And I'm not trying to say anything bad, but when my doctor got in to me, he said he was surprised how bad it was. You know? And, So I wonder sometimes about the MELD score, if it's really, I guess it's the best for what we have. But for me, if I hadn't had the HIV, I don't think I would have gotten the transplant.
Yeah. Well, I hope I made the case that the MELD score isn't perfect. And we have some ways around that. But you're right. There are issues. It's hard to get better than it. We haven't found anything better yet. And there are a lot of attractive things about the MELD score, even, beyond, like I said, the accessibility, et cetera, makes that very compelling. But you're right, it's not perfect.
One last thing, and this should be good for anyone who's post-transplant. I'm heading for 3 years, and I take 0.5 Prograf every 6 days.
Wow.
Isn't that wild? It stays in my system a long time, but I'm doing very well on that.
Yeah, that's uncommon. But that's also why we follow levels. And not everyone has the same dose because people's metabolisms are different.
Well, I'm getting a blood test every month still.
Great.
And we're monitoring it. And Dr. Washington, she says, okay. So I'm
Good.
cool with it.
I trust Preeti. Yeah. Well, if there are no other questions.
Dr. Webb,
Oh, yes. Sorry.
could you expand on fatty livers? How does one get it? And
Yeah. So fatty liver is a metabolic phenomenon. It is all related to what we call metabolic syndrome, which is driven by obesity, diabetes, sedentary lifestyle, blood pressure issues, heart disease, et cetera. The same thing going on in your heart and in your pancreas for diabetes is also resulting in fat in the liver. Fat in the liver doesn't all come in the same flavor. You can have what we call simple steatosis or simple fat, and that is just fat in the liver with no inflammation. Then, and we think this is a continuum, that fat can start inciting inflammation. And when that happens, the damage from the inflammation causes scar tissue. That scar tissue builds up, and that's how you get cirrhosis. Cirrhosis is just the end point of a lot of scarring in the liver from whatever the cause, whether that be inflammation in fatty liver, inflammation from hepatitis C, hepatitis B, whatever, alcohol, that's what causes cirrhosis. And so because we have a Western lifestyle over here and we have an obesity epidemic, we also have a diabetes epidemic, a metabolic syndrome epidemic, and a fatty liver epidemic.
Mm-hmm. Well, I have a question. My daughter, my name is Shivania Holmes. I'm the mother of a liver transplant patient. She received her organ 19 years ago.
Wow.
When she was on Neoral a few years ago, her hair was growing very thick and long. And now she's transitioned, well, she transitioned over a few years ago to tacrolimus.
Mm-hmm.
She has had an increase in the tacrolimus. She has early signs of the fatty liver disease. Her hair is not growing as thick as it used to be. Is that a direct result of the increase of the tacrolimus or the fatty liver disease, or the combination of both?
The hair itself?
Yes, her hair is just not as thick and it's not growing as fast. And she takes biotin every day.
Yeah, so that's one of the less common side effects of those medications. Some people, and if I remember correctly, Neoral might have been one of these. We use less cyclosporin than other things, but can cause some what we call hirsutism, so more hair growth.
Yes.
Can I ask, is she doing well overall?
I mean, yes, she doesn't have any symptoms at all. She's an active college student.
Yeah, sometimes hair loss is more a manifestation of overall health. But I do hear complaints occasionally about hair loss on immunosuppression regimen. It's usually early, less so in the later times, but I mean, maybe the increase has impacted that.
Yes, it's more of the slow growth of the hair. Her hair is just growing very slow. She takes a multivitamin and like I said, the biotin, but it doesn't seem like her hair is growing very fast at all. But her nails are growing, those type of things. So I don't know. So
I'm not sure, but it could be.
Sure.
Yeah, I wouldn't mind if my hair grew a little less quickly.
Yeah,
Fewer haircuts, don't have to shave as often. That would be great.
sure.
Okay.
Okay, thank you so much.
Sure. Yes.
I am coming up on 17 years out. I used supplements from about 2007 until this past March.
Sorry,
I
you used what?
Sirolimus, Rapamune.
Uh-huh.
I began to develop chronic respiratory problems. I was getting almost near pneumonia-like symptoms every couple of months. I'm back on Cellcept and prednisone. My local physician is concerned about the prednisone. Is there a point in time where I can press to reduce the amount of prednisone, or am I just going to have to follow that regimen, as a matter of course?
It's hard for me to comment, not knowing all the details of your case, and it would probably be irresponsible for me to do so. In general, need of something like prednisone and the doses of it are going to depend on tolerance of other options. In your case, maybe you didn't tolerate the Rapamune. Rapamune is associated with a pneumonia type picture. It's more of a pneumonitis, so inflammation of the lungs. I usually associate it with happening earlier in the course of being on Rapamune, not a decade or more later. But it makes you wonder if there's another cause for your lung problems. But regardless, sounds like your providers don't think you should be on that anymore.
I cycled through Prograph and experienced some kind of neurotoxicity with extreme stuttering and panic attacks and so forth. Cyclosporin, created the kidney problems that you've talked about, and that's why I eventually ended up on Rapamune. And I was on only 1 milligram a day, and I thought I was doing very, very well until just about a year and a half ago, when these bronchial symptoms became chronic.
Well, it is a balancing act of, what can you tolerate? What are the side effects? And how's your liver doing? And so while I can't give you specific advice, I can only assume that your transplant hepatologist is taking all those things into account.
Well, so I'm, I consider myself to be pretty well. I mean, I am pretty active physically.
All right, I'm trying to listen.
I'm doing well.
Good. Good. All right. Other questions?
Hi. No, I have a question. With the liver transplant, are you allowed to have a small amount of wine or no?
I say no wine is good wine. It's just, there's no study that tells me having occasional wine is going to cause a major issue. Okay. But I kind of think of it as risk benefit, right? So what's the risk? Well, the risk is twofold, depending on your history. If wine and alcohol becomes a problem, it can definitely do serious damage to your organ. Two, if it's a problem or even just occasional, it could reduce your candidacy for another transplant if you needed it. What's the benefit? I guess some social benefit to drinking alcohol. I don't know where I don't know. It seems like it's mostly risk, even if that risk is small.
Okay, because I normally don't drink, but I've been under so much stress, I just want a little sip.
Yeah, well, that would be the wrong reason to drink alcohol, I think. So be careful. I recommend avoiding it. Okay.
Okay, thank you.
Sure.
I just wanted to thank you. You covered my Prograph and Cellcept, and I quit Cellcept probably about a year afterwards. That was way back in 2008. But I want to thank you for all your information. I listened very carefully. And I've been away from Piedmont for quite a while. I've been going to the VA. But just in case, if you still have Dr. Cheriska.
I don't know Dr. Cheriska.
Cheriska.
She was at Piedmont?
Well, he was, yes.
He was. Yeah, I don't know. I know the guys, the folks at Piedmont, but I don't think he's still there.
No, and he might not be, might be retired by now. He saved my life twice. So
Oh, you mean Shrestha? Oh,
yeah.
Roshan. Yeah. I know
Oh,
Roshan.
well, Ted, you can tell him Paul said hello. He saved my life twice.
Okay. I'll let
Matter
him
of
know.
fact, they called him in a meeting in Chicago one day when I was in the hospital, and he told them what to do to save my life. But he saved my life a couple times.
Wonderful.
He'll know who Paul is. He'll remember.
Okay.
All right. Thank you very much for
Doctor,
all
I
your
have a
time.
question.
Sure.
Given the COVID situation and the potentials for COVID vaccinations and all that, do you have any preliminary feelings on whether or not we can take those?
It's going to depend on what comes to the forefront, I think, and we don't really know that yet. I've been concerned about the political meddling, but I'm reassured that something wasn't fast forwarded so much that it, came out a few days before the election, for example. So I've been telling patients I'm going to reserve my judgment until we know what's available and that the medical community and the research community can learn all the things that went into that development. And then we can make a recommendation, and hopefully, if that recommendation is we think this is safe and effective, then the population will do it. But if that's a problem, you can have an 80%, 90% effective vaccine, but if only 5% of the population feels willing to take it, well, it doesn't help much, right? Whereas if you had a 40% effective vaccine that 100% of the people would be willing to take it, well, that's better than the first example I said. So it really, the general public's trust is very important here. So I dodged your question.
It's the political season. You have to take the no answer.
That's right. Yeah, I will be a politician one day, maybe. Well, I would love to go through these cases, but I think we've hit over an hour here, and I honestly need to go into the hospital and around, so I might break now. But I really
perfectly fine. I am so thankful that you took the time and extended well beyond the time originally allotted to educate us about what's going on. As a quick reminder, I just want to let everyone know that an email will come tomorrow with a quick survey, and we are counting on you to take a few minutes to complete this so we can improve our conferences for 2021. Thank you for coming today.
thanks so much, guys. Great to talk with you.
Thank you, Dr. Webb.
If you have any questions, please reach out to us at GTF. We would be happy to help. Y'all have a great day.
Thank you.
Thank you so much.
Bye.
Bye.
Thank you. Bye-bye.